Hello and welcome to 5 and 5, the only place to get 5 valuable clinical tips you can start using ASAP in 5 short minutes. I'm your host and fellow dermatologist Gary Goldenberg, and today I'm joined by my good friends Drs. Adelaide Hebert and Dr. Jonathan Silverberg with 5 clinical tips in the management of atopic dermatitis. Adelaide, we're going to start with you. Let's hear your tips on management of atopic dermatitis.
Thanks, Gary. I think the most essential foundation component of success in managing atopic dermatitis is education. We have to educate our parents and our patients, if they're pediatrics, sufficiently such that they are going to have a good, successful therapeutic intervention and get their atopic dermatitis under control. We want them to understand there's currently no cure for atopic dermatitis, and caring for atopic dermatitis takes time.
I think it's a great tip, and certainly patient education is very important. Let's hear your next tip.
Well, I think that all patients with atopic dermatitis need to be aware of the fact that a ceramide cream can help repair the defective barrier. If they apply a ceramide-based cream 2 to 3 times a day, they can actually help heal and seal that defective skin. I tell parents of small children, think about the child's skin as being covered with polka dots. Those dots let the water come out and the trigger factors come in. They have the ability to work with that child to heal and seal the skin with a ceramide-containing agent applied 2 to 3 times a day.
And what about patients who cannot tolerate ceramides?
I have a tip for them too. They can think about using zinc oxide ointment. They may have to get their pharmacist to order it for them, but here's an illustration of what I'm talking about. It's not white and sticky. It goes on very readily. It is ointment based, and patients tolerate it extremely well.
It's a great tip. Let's hear your last tip.
All right. I think that it's important to control the colonization or frank infection of the skin. This can be done by using dilute bleach baths on a daily basis, or they can just simply bathe and examine the skin and look for crusts or fissures in the skin. The dilute bleach baths in my clinic work very, very well, and I think we've had outstanding outcomes by helping patients have less staph on their skin, and that is a key driver of disease control success.
I think many of us use bleach baths as an easy and inexpensive way to control colonization. These are great tips. Thank you. Jonathan, let's turn to you and hear your tips.
Sure. So I think it's important to recognize that patients with atopic dermatitis may often have overlaps with allergic contact dermatitis. Even patients with long-standing atopic dermatitis can eventually develop the allergic contact dermatitis. So this is an example of a young woman who had lifelong atopic dermatitis, presents with recent onset eyelid dermatitis, and upon patch testing is found to have a 2+ reaction to lanolin, which is present in so many of her personal care products. And so that was something that was developed later on in life and really is now exacerbating the atopic dermatitis. And so when to patch test patients with atopic dermatitis, it's going to be the patients with adolescent or adult onset, not those classic childhood onset scenarios. Those with a localized or atypical distribution may not be that classic symmetric bilateral distribution. And if the disease is more recalcitrant, not responding to topical therapy the way you would expect, and certainly if you're starting to think about the use of systemic agents, it's worth patch testing them just to see if you can keep them off of it on the chance that you find a positive reaction.
Certainly difficult sometimes to tell the difference between chronic contact and chronic atopic dermatitis. That's a great tip. Let's hear your next tip.
Sure. I think now it's becoming more important than ever as we move into an age of precision medicine, being able to differentiate between psoriasis and atopic dermatitis. Certainly there are those textbook cases which are pretty easy to distinguish. You have an example of a case of plaque psoriasis with these very well demarcated, thick, bright red lesions with micaceous scale. And when you see that, it's pretty much a no-brainer that it's psoriasis. On the other end of the spectrum, when you have that classic flexural distribution, the ill-demarcated lesions, more of that subtle pinkness and the prominent lichenification, that's also a fairly clear diagnosis for atopic dermatitis. However, you can have patients that are sort of somewhere in the middle, and they can have maybe a little bit more of a pinkish color, sometimes more diffuse or generalized lesions, not clearly with that extensor distribution. But don't be fooled. If overall the lesions are more psoriasiform, even if there's a little lichenification, that's really going to point you in the direction that it's more psoriasis.
So it seems that spending time with the patients, whether it's education or careful physical exam, is really important.
Absolutely.
Thank you both for your tips. This is 5 and 5. Until next time.